the coronaviral infections past and present during the next 10 minutes or so. Presentation overview, I will be briefly talking about the introduction, then a little bit about the coronaviruses, especially the SARS coronavirus, MERS coronavirus, and in more details about the SARS coronavirus 2, including about the virus, origin and the intermediate host, transmission, pathogenesis, and the viral kinetics. Let us look at a brief introduction to the current situation. It is started with the reporting of cases of pneumonia of unknown etiology from Wuhan, China in December 2019. In January 2020, China submitted the genetic sequencing of the new coronavirus identified from these patients, and it was named as 2019 novel coronaviruses or 2019 nCoV. The genetic homological studies found that the novel coronavirus was almost identical to the SARS coronavirus, not identical, has a high degree of genetic homology. Therefore, the International Committee of the Taxonomy of Viruses renamed it as a severe acute respiratory syndrome coronavirus 2 or the SARS-CoV-2. Following the renaming of the virus, WHO renamed the disease as the coronavirus disease 2019 or the famous COVID-19. Coronaviruses are a large family of viruses infecting animals and birds. They belong to 4 genera: alpha coronavirus, beta coronavirus, gamma coronavirus, and the delta coronavirus. Of these viruses, 7 coronavirus infects humans. In this image, you can see in the corner the SARS clade and the current virus, that is the SARS coronavirus 2, and the close relationship in the phylogenetic tree. Of the 4 human coronavirus, of the 7 coronaviruses that infect the human, 4 are human coronaviruses, and they usually cause mild upper respiratory tract infection. Of this, 1 is an alpha coronavirus and other 3 are beta coronaviruses. Then there is 3 animal coronaviruses that infects human. All 3 are beta coronaviruses. They produce severe respiratory tract infection in humans. The first one is the SARS coronavirus or the SARS-CoV, which is responsible for the SARS outbreak. The second one is the MERS coronavirus, which is responsible for the MERS outbreak. The last one is the SARS coronavirus 2, which is responsible for the current COVID-19 pandemic. Severe acute respiratory syndrome coronaviruses. Let us look at the SARS coronavirus. This virus was first detected in human in Guangdong province in China in 2002 November. Importation of the virus caused outbreaks in other countries, mainly in Canada. There was a huge outbreak in Canada. In addition to that, there was outbreaks including Hong Kong, Taiwan, and Singapore. About 20% of the human-to-human transmission occurred within the healthcare settings. This outbreak lasted from 2002 to 2003. During the outbreak, it affected 29 countries, more than 8,000 cases, with more than 700 deaths. Case fatality rate was 11%. The outbreak was controlled in July 2003, and there were no SARS cases detected since 2004. Now let us look at the MERS coronavirus. It was first detected in Jordan in 2012, and it causes the outbreaks in Middle Eastern countries. These are localized outbreaks. In addition to the outbreaks, there are sporadic causes occurring or reported from elsewhere. Since 2012 up to date, more than 2,500 cases has been reported with 876 deaths, giving the case fatality rate of 35%, much higher than that of SARS coronavirus. Like SARS coronavirus, the MERS coronavirus also primarily transmitted from human to human within the healthcare setting and within the families. Now let us look at the current virus, SARS coronavirus 2. It's an envelope virus with a positive sense single-stranded genome. It has a glycoprotein spike on the envelope. And this is important in the infection of the virus in the respiratory tract. It binds to the angiotensin converting enzyme 2 receptor of the epithelial cells of the respiratory tract. Currently, 3 clades of the SARS coronavirus 2 have been identified. Clade A and Clade C are found in Europe and in America. Clade B is mainly found in East Asia. The few isolates which has been sequenced from Sri Lanka all belongs to the clade A. This points out to the origin of the virus. It is likely that it is from Europe or America rather than from the East Asia. Now let us look at the origin of the SARS coronavirus and the intermediate host of the SARS coronavirus 2. MERS coronavirus and the SARS coronavirus 1, we can say it 1, are bat viruses. Of this, MERS coronavirus transmitted to the human via the intermediate host camel. On the other hand, the SARS coronavirus 2 coronavirus transmitted to the human via the civet cat. So the MERS coronavirus intermediate host is the camel. SARS coronavirus intermediate host is the civet cat. What about the SARS coronavirus 2? Origin of the SARS coronavirus is thought to be bat virus. It is a bat virus. This is supported by the fact that there was a SARS-like coronavirus have been identified from the bats. And they have a more than 96% homology with the SARS coronavirus 2. What about the intermediate host for the current virus? Earlier it was thought the current virus is passed to the human through the snail. However, now the latest information supports the pangolin as the intermediate host. Coronavirus, similar to SARS coronavirus 2, has been isolated from pangolin, supporting this hypothesis. How does the SARS coronavirus 2 transmitted from human to human? The main mode of transmission is the droplet transmission. This occurs between 2 people standing between about 3 to 6 feet, and it is through the inhalation of the droplets. In addition to the droplet transmission, contact transmission also important. This is via the hand touching contaminated surfaces, in turn touching the face, especially the nose, eye, and mouth, thus transferring the virus from contaminated surfaces to the nose, eye, or mouth. In addition to these 2 modes of transmission, that is the droplet transmission and the contact transmission, aerosol transmission also important. However, aerosol transmission is restricted to the aerosol generating procedures occurred in healthcare setting, like bronchoscopy, insert in the endotracheal tube, like that. Then let us look at the pathogenesis of the SARS coronavirus 2. Exact pathogenesis is not known. However, the hypothesis suggests that the virus binds to the ACE2 receptors of the epithelial tract of the upper respiratory tract, mainly the nasal passage. This will lead to the localized infection. There is a virus excretion in the nasal secretion at low level, starting with the innate immune response. The second stage, infection spread to the upper respiratory tract, the rest of the upper respiratory tract. There is an enhanced infection and the patient will be presenting with mild to moderate disease. There is an enhanced virus excretion. However, the immune response is still the innate immune response. In the next stage, the virus spread to the lower respiratory tract, including the lungs. This happens in about 20% of the cases who are presented as severe cases. Virus is found in the lower respiratory tract secretions. By this time, in addition to the immune response, the acquired immune response also in place. From the lower respiratory tract, especially from the lungs, the virus entered the bloodstream. And then it is spread to the other organs expressing the ACE2 receptors, like heart, kidney, and gut. The virus replication in the gut will lead to the excretion of the virus in the stools. Exact time of the onset and the duration of the virus excretions is not sure. However, the virus is present in the respiratory secretions 1 to 2 days before the onset of the illness, about 1 to 2 weeks after the onset of the illness in the case of mild infection. However, the virus excretion may last for several weeks in more severe infection. Therefore, the period of infectivity starts 2 days before the onset of the illness, and it can go up to several weeks after the onset of the illness. Earlier, it was labeled as 2 weeks after the onset of illness. However, now it is extended up to several weeks because of the virus has been detected in respiratory secretions for several weeks after the onset of the illness. In addition to the respiratory secretions, virus also found in stools. In addition to the respiratory secretion and the stools, virus also found in semen, blood, and in breast milk. However, the virus found in the stools, semen, blood, and breast milk, the exact importance in the transmission is not sure. In summary, I have introduced you to the current situation very briefly. Then we have given a short summary on coronavirus, SARS coronavirus, and the MERS coronavirus, and more detailed presentation on the SARS coronavirus too. Thank you very much.
Thank you, madam. Thank you very much. It's really, it's a very informative lecture. The next one is on global and Sri Lankan situation, COVID-19. Dr. Champa Vijay Singh is going to deliver the next lecture. I don't know if Champa is around. Champa, are you there?
Yes, sir.
Right.
Can you hear me?
Yeah, we can hear you.
Now I'm going to share my presentation with you all. Thank you, Dr. Heda, for inviting me to join this seminar. And I'm going to present you some data from the epidemiological point of view so that you can have some idea about the distribution of coronavirus in worldwide and in Sri Lankan setting. So I hope the screen is, the slides are available to you now.
Hello.
Can you see the slides now?
Yeah, we can see.
Hello?
Yeah, we can see. Please go ahead. Yeah.
Okay.
We can see.
So Yes, most of the information that I share in these slides are from the official websites of the World Health Organization and the Epidemiology Unit of Sri Lanka. So if you want more detailed information, you can visit this website and get up-to-date information. So the information in this presentation is updated information available at midnight yesterday. So if you just look at the timeline of the COVID-19 infection, it was first officially reported on 31st December 2019 as an outbreak of pneumonia of unknown etiology in Wuhan city in Hubei province of China. We all know that. And by 7th January 2020, it was diagnosed as novel coronavirus. And on 30th January 2020, World Health Organization declared the disease as a public health emergency of international concern. And on 11th March, it was declared as a pandemic, which is a worldwide epidemic. As for Sri Lanka, we had our first confirmed case of COVID-19 on 27th January 2020, and it was a Chinese tourist. And 11th March, we had our first Sri Lankan national who is tested positive for COVID-19. Now, from that onwards, the latest numbers in the world, according to the World Health Organization situation report, in this slide, you can see the total number of cases and the cases in last 24 hours within brackets, depending on the WHO health region. So globally, we have approximately 4.3 million cases, and the death toll is approximately 300,000 deaths worldwide. The highest number of cases are reported in America region, which is about 1.8 million, and the total deaths are about 110,000. And this is followed by the Europe and the Eastern Mediterranean countries. If you consider the countries in the American region, United States of America, highest number of deaths, followed by Brazil and Peru. The number of cases but in Europe region,
Champa, Champa, can you hear me? Champa, can you hear me? Hello, Champa, can you hear me?
Followed by United Kingdom and Spain. However, the death toll is higher in the
Champa, can you hear me? Champa, can you hear me? There's an issue with the internet connection, I guess.
Problem with
Yeah, I think there's a small issue with the internet connection, so we'll have to fix it. Can you all just wait? Hello, madam. I think till we fix that, we will ask next speaker to give a lecture. The next speaker is Professor Bodhinayaka. She's going to talk to us on clinical features and complication of COVID-19. Over you to madam.
First of all, can you hear me clearly?
Yeah, we can hear you.
Yes, we can hear you.
Yeah, and also the slides are seen. Right.
Correct,
so we may move to clinical features of COVID, which is very important for all of us as clinicians. So I am sure so many of you know many things about COVID, but we need to know a few important things. To start with, COVID-19 infects people of all ages, and how it causes infection already described. In a simple version, it kills the airway epithelium and alveolar cells, and a specific immune response is required to eliminate the virus and get rid of it. Only people who are in good health can achieve this. So people who are not in good health will have problems. So the pathology is other than the unusual component of COVID-19 is, with the infection, the pneumocytes will secrete certain chemokines, which will actually, or cytokines in other words, which will recruit more and more white cells, which will be little misdirected or dysregulated, and they will kill more. So that is how the severe disease happens. So this is called a cytokine storm. So people must be in first years as well. So therefore, it is something, your own immune system is dysregulated and hyperstimulated. And these chemokines are, we know that they are interleukins, tumor necrosis factors, colony stimulating factors. There are so many which will be dysregulated and which will recruit many more lymphocytes, neutrophils to the site and kill your own alveolar cells and the rest of the tissue. So that is how the disease, the pathogenesis is. The host has to be in very good health to achieve this. So hosts who are elderly, it is shown in almost all the studies, age is a major risk factor. Above 55 years, and with aging, it progressively the risks are increased. Then the other comorbidities, notably hypertension. Out of many, hypertension is one of the most dangerous. And then diabetes, coronary artery disease, cerebrovascular disease, malignancies, kidney disease, lung disease, and obesity, and not forgetting already existing previous lung disease. So there are 10 risk factors I already mentioned. They actually put the host to a risk of having severe disease. So let's look at the clinical spectrum. Everything is in a spectrum. It could be asymptomatic, mild, severe, critical, or fatal. So asymptomatic, what is the percentage? It's very difficult to figure out. Research would say it is about from 5% to 80%. We know our cohorts are mostly asymptomatic, like the Navy cohort, where the people are fit and well, young, healthy. No one will be taken to the Navy if they are kind of having comorbidity. So therefore, that cohort is actually asymptomatic. In other cohorts in different countries, it depends on which cohort you are looking at. Hospitalized cohort will be always symptomatic. So it depends on which cohort you are looking at. One cohort I would like to mention, like the Diamond Princess, the ship's cohort will be a good one to look at. and out of the 600 odd people, about 18% were asymptomatic. So asymptomatic category also may not be asymptomatic for a long time. They may be already pre-symptomatic, but in the due course, they are likely to become symptomatic. So asymptomatic may be still pre-symptomatic. All these people could still infect another patient, another person. The next step would be mild disease. That is either a very mild pneumonia or absent no pneumonia. It's the majority of the patients who are symptomatic, around 80% will have mild disease. So it's not so bad. But 15% will have severe disease, 5% will have critical illness like shock, respiratory failure, multi-organ dysfunction. I said that it is actually attacking your own cells, right? You are dysregulated, your cells are misdirected to attack your own cell. So therefore, 2.5% could be having a really critical illness, which is fatal. So recovery will require a vigorous innate and acquired immune response and epithelial regeneration. So it takes a lot of time. So that is the clinical spectra. And mild disease, I would like to mention, a telephone survey found that 2 out of 3 reported with the positive cases had an altered smell or taste. So altering of the smell or taste is well reported. And some people who have mild disease, who go on having mild disease for about 2 weeks without worrying symptoms, are likely to be on the road to recovery. So if you have still mild symptoms after 2 weeks, you are going to recover. Some people with mild symptoms will progress. We will look at the percentages, how they progress. So this is a slide that I really like to compare as a clinician, because patients come with symptoms, not with diagnosis. So therefore, we need to know at least some clues. There are not many clues. COVID-19 also might look like influenza and coryza when it is a mild disease. So these are the important symptoms. 3 important symptoms is dry cough, fever, and shortness of breath if the disease is more than mild. So otherwise, if it's a mild disease, mainly the dry cough and the fever. You have to notice that nasal discharge and sneezing, those are not actually features of COVID. They are generally features of a common cold, or what often called hemorrhage. So nasal discharge and sneezing are not the big features of COVID. But you can see sore throat, breathlessness, headache, body aches, fatigue, and diarrhea. It reported in different cohorts as different percentages. So all those could be features of even mild COVID. So in comparison to influenza, actually both are the same, not very different, but you can see lot of headaches and body aches and fatigues in influenza, which are slightly less common. I don't know how these are very useful in a clinical setting. But remember that nasal discharge, sneezing, rhinorrhea, those are not features of COVID, but they are common features of a common cold. So this is mild disease, and that mild disease at diagnosis, I said 80% are mild, 15% are severe, and 5% are critical. So out of this mild disease, they don't be mild forever. Sometimes 10 to 15% of mild to moderate cases can become severe. And out of those, and out of the severe cases also, about 15 to 20%, that is almost 1 in 5, can become critical. So that is how the disease progresses in COVID. So you don't have, a person might not stay at a same level. There's a chance of changing over. But if you have been mild for 2 weeks, you are unlikely to become severe. Right, let's look at the more interesting part is severe COVID. There are 3 typical symptoms of severe COVID, that is fever, dry cough, and dyspnea. So these are 3 cardinal features of severe COVID. Mostly, majority of severe COVID will have a fever, and 2/3 will have dry cough, and 1/3 will have dyspnea. So there are other features like sore throat, headache, fatigue, diarrhea, like I already mentioned. Physical signs are not much reported in the literature. So in whatever is reported is probably like a viral pneumonia where the radiology is more than the physical signs. In a viral pneumonia, the radiological signs are much more sensitive than the physical signs. Physical signs may be minimal. So in radiology, I am sure it will be discussed in next speakers. Bilateral pulmonary infiltrates on chest imaging, not necessarily bilateral, it could be unilateral as well. On chest imaging. So actually imaging studies are much more important than physical science. So also sometimes you have to remember there could be longer duration of symptoms prior to ED presentation, like a bacterial, unlike a bacterial pneumonia which worsens over days. Sometimes COVID can stay like with moderate symptoms for a while before they become really worse. Actually, it is associated with the pathogenesis which I described. So this is a slide to show that it could be actually not very severe patch of consolidation, which could be really bilateral and ground glass, and patchy consolidation, which could be really more extensive with interstitial shadowing. So it could vary. The radiological features could vary, but mostly they are subpleural, they say. So in lieu of physical signs, I will just show the few pictures. So this is COVID pneumonia. It could be actually not only consolidation, ground glass, interstitial, all the any feature could be there, but an effusion is not common. Effusion is an uncommon finding. Right. So this is the classification of a severe COVID: mild, moderate, severe, and critically. Let's concentrate on the severe because mild and moderate we already know. So dyspnea with a respiratory rate, high respiratory rate, saturations low, multilobar disease, or disease progression more than 50% within 48 hours. That means rapidly progressive disease, that is severe. And a SOFA score, I'm sure you know, more than 2, and pneumothorax or other clinical condition requiring hospitalization is a severe COVID. And critically ill COVID are people who have respiratory failure requiring mechanical ventilation or septic shock or additional organ failure. We look at what organs could be damaged. Right. Now, lung damage. Let's concentrate first on the lung damage. In COVID, it is not totally ARDS, because what according to emergency physicians who actually ventilate these lungs have two patterns. One is ARDS pattern where there's a reduced lung compliance, but also there's a good lung compliance where higher tidal volumes could be delivered, but severe hypoxemia is there. They are mostly due to ventilation perfusion mismatch, like what we see in other pneumonia. So lung damage in not only ARDS but also pneumonia. So two pathologies can exist with lung damage in COVID. Right. Now what happens after? What happens after? So the patient will have a very long course of illness, and severe cases will be needing some kind of respiratory support or ventilation, which will be discussed. And then ultimately mild cases. So how does the recovery happen? Mild cases, from symptom onset to recovery, takes about 2 weeks and they recover. That is how we see these all Navy personnel who have recovered and are sent home. Severe cases, we know that there are so many cases still being hospitalized, right? 3 to 6 weeks from onset to recovery. Death can occur from 2 to 8 weeks, till about 2 months later even a person can die. So it's a really prolonged course. Right. So let's look at how it affects the other organs. So respiratory disease we already know, right? So cardiac injury, as said, the angiotensin receptors are in the other organs as well. So cardiac injury like worsening arrhythmias, heart failure, or new onset myocardial infarction, cardiomyopathies, troponin levels, all forms of cardiac injury is reported with COVID. A severe COVID, it could be amounting in 1 in 5% will have a cardiac injury. Then renal failure, they call it a not much of how it happens, the mechanisms are not yet revealed. So I know we are still in a very evolving phase. So what we discuss right now may not be exactly the same in another couple of months. So please remember that. But whatever is observed is renal failure due to hypercatabolic state, and always the potassiums are very high and needing dialysis. Then the liver failure, not so much, and liver not so much as the cardiac or the renal, but DIC, venous thrombosis, they are well reported. Shock and multi-organ failure, again well reported. Secondary bacterial infections, actually 50% people who have died and who had autopsy findings have had 50% had bacterial infections. Almost 100% of severe cases will receive antibiotics. So they are now discussing antibiotic resistance. How will it happen in this COVID era? Because there's a lot of antibiotics which are used. Almost everybody in the ICU is receiving an antibiotic. So neurological complications like ataxia, seizures, cerebrovascular disease, encephalopathy, and all those things are very, very well described neurological features, late neurological. I'm sure we will have much more features coming up later. So neuropsychiatric effects, I'm sure we should not forget, not only the physical, but the neuropsychiatric effects could be really detrimental to a patient or family or the community's health. So all these are complications. Right. So I'm coming to an end to my presentation. So very few predictors of mortality, but one of the major would be older age and concurrent medical illness like coronary artery disease, cerebrovascular disease. Elevated troponins, there is again predictor of mortality. We are discussing predictor of mortality, not severe disease. Severe disease, there are so many other things identified. Low CD3 and CD8 T cells is also found to be as a predictors of mortality. So this is all what I need to tell you. So it presents in several forms of with a big clinical spectrum, which has a potential risk from one section to go to the other and a potential risk of death. So it's prevention and actually avoiding and all the public health measures can never be replaced with anything. Right. Thank you.
Thank you, madam. It's very informative lecture. Thank you very much for that informative lecture. Next, since we had issue with Dr. Champa Vijayasinghe lecture, we will try to connect her again. So I will share her slides and probably she can join from other end. Champa, can you hear me? Champa, are you there?
Herat, if Champa is getting having a problem, I'll be happy to do mine. I will take about 5 minutes to talk.
Okay, so we'll do that. Let me stop this one and change. Arosha, do you have the presentation with you or do you want me to share it?
If you can share just 2 slides, Herat, if you can share that to me, I'm using the iPad.
Okay. And so we will do that. I will do that.
It's a little difficult for me to link it up to this one.
Yeah, okay, so we will see. Right.
Yeah, thank you. That's fine.
Thanks, Arosha.
Right, fine. Very good morning to all very dear medical students. I hope all of you are keeping very safe and keeping very well and looking forward to coming back to the university. Now, thank you, Dr. Herath, and for organizing this seminar, which I think is very important. Now, let's look at this whole process from starting from the end. You know, you all are medical students, and how is knowledge of when to diagnose COVID and how to diagnose COVID, how is that going to be useful to you? One is, of course, already, I'm sure, in wherever in your villages or towns or while you're at home, your relations and friends must be calling you when they have certain symptoms and asking you for advice, because they know that you're a student of medicine, they're going to be a doctor soon, and they must be calling you and, you know, getting in touch with you and asking, you know, what to do. So you need to be able to give them the advice that they require. Second thing is, ultimately, when we open the universities and when we open, Herath, is everybody hearing me? Herath, are you hearing me?
We can hear you, Arusha.
Yeah.
Go ahead, please.
Right, fine. I wasn't sure. Right. And the second thing is, of course, when you do come back to the wards, then you will be clerking patients, you will be seeing patients. Of course, those patients would have been evaluated by other doctors, also a number of other doctors. But then again, you will again have to deal with patients with all sorts of febrile illnesses and respiratory illnesses, and you need to make your own assessment. When you meet people in the community, when you're in the hostel, when you're in other places, community, again, you will come across patients or people with certain symptoms. They may either seek your advice or you may want to know about them. So from all these angles, as a medical student, you need to have some very core knowledge about how to diagnose COVID-19 illness. So that is what I'm trying to cover, and I will be using only 2 slides, and I will be looking at this whole thing from the perspective of a medical student. Herath, may I have the next slide, please? May I have the next slide, please? Thank you very much. Now, COVID diagnosis is done, diagnosis, not assessing for complications, etc. Diagnosis is done in 2 steps carried out sequentially. First is the epidemiological unit of Sri Lanka under the Ministry of Health. Of course, after discussions with the Sri Lanka College of Internal Medicine and College of Physicians, etc., have defined 5 groups of people who may be having COVID-19 illness. So this is the suspected case definition of COVID in Sri Lanka. Now you need to remember these 5 categories. So if somebody were to call you and ask you from home, you know, I have these things, so you need to make a mental assessment. Could this be COVID? Or is this non-COVID, in which case you can reassure them that they are well. Or if you think it is COVID, then you can advise them to come to a hospital. So let's look at these 5 criteria. This is the case definition, clinical definition of COVID. First thing is, the patients need to have an acute respiratory illness, ARI. The 4 symptoms of acute respiratory illness, which the epidemiology unit has highlighted, are fever, cough, sore throat, and shortness of breath. Now, all of this may be present, or some of these may be present. It is not essential, but fever is considered to be the first among equals of these, or the most important of these. So we are looking at a patient with fever who has maybe cough, maybe sore throat, maybe shortness of breath. That's the acute respiratory illness. There have been some patients who have been diagnosed, that's very rare, without fever, but cough, sore throat, shortness of breath. That can happen, but that's not a frequent occurrence. Usually patients with COVID illness have fever plus 1 or more of cough, shortness of breath, and sore throat. So first thing is to see whether the patient has acute respiratory illness as defined here with these 4 features, and then check, have they had overseas travel within the past 14 days? Now, at the moment, airports in Sri Lanka are closed. So you might wonder, why have we included this as a criteria? The reason is when these were drawn initially, people were returning from overseas. Even now, some people are returning overseas, but everybody is sent to quarantine. But very soon, now COVID-19, as the previous speakers have told you, is not going to go away in a hurry. COVID-19 will last for maybe another year or even more. And we will open our ports, we will open our airports, and people will come from overseas and be in the community. So when you see patients with ARI, and if you want to make a decision, check whether there has been overseas travel to any country for over the past 14 days. Second thing is, a patient with ARI, the second question you will ask is, has this patient been in contact with a COVID-19 patient? Not a foreigner or anybody, but a COVID-19 patient, somebody who has been in IDH for COVID-19 illness. Then again, that becomes a possible case. So A and B. C is again acute respiratory illness. And here there is no overseas travel history or close contact with a COVID-19 patient, but it is residence in a high risk area. Now, high risk area is not a particular district, but certain so-called red zones which are episodically defined by the epidemiology unit. Now, you all know that there was a village called Pannila, there was an entire area in Bandaranaike Mawatha in Colombo 15, and then there was Obesekarapura. So certain areas are defined by the epidemiology unit as high-risk transmission areas or red zones, and then people are cordoned off, etc. in that area. So whether the patient has either resided in that area or has been a visitor to that area. So these things, it is important to remember, change periodically. Now, at this moment of time, though there were certain red areas in Kalutara district, there isn't a single red area in Kalutara district. There isn't a single red area, to my knowledge, I don't think so. But certainly there is no single red area in Galle. So third thing is, if somebody has acute respiratory illness, you need to find out, has there been any residential exposure within the past 14 days? Again, I'm sorry, I forgot to mention, with a acute respiratory illness with close contact of a COVID patient in criteria B. Now, what is close contact? Close contact is not seeing them at a distance or something, but it is required that you be in contact with, at least the person with acute respiratory illness has to be in contact with the COVID patient for more than 15 minutes, and there has to be close physical contact as well. So maybe, you pass one of them on the road or something, COVID is not going to jump from that person to you. So acute respiratory illness and prolonged and close. Those are the two important words, prolonged and close contact with a COVID-19 patient. So I think we have covered criteria A, B, C, both referred to acute respiratory illness patient with three different exposures: overseas travel, close contact with a COVID-19 patient, or residence in a high-risk area. Now, there are two other groups of patients. If somebody contacts you, or if you see a patient, if you see a patient who has an unexplained pneumonia. Now, unexplained pneumonia is not pneumonia. We know that all the time people in the community acquire community-acquired pneumonias, and they get lobar pneumonias with high white cell counts and X-rays in a lobar area of lobar consolidation on an X-ray, high white cell count, and we know that streptococci are probably the commonest organism, etc. We know all about community-acquired pneumonia. So we are not talking about a typical community-acquired pneumonia. And we know if a patient has had a seizure or been under the influence of alcohol and then aspirated and then get a pneumonia, that's aspiration pneumonia. This is not aspiration pneumonia. Or patients are in hospital for some other illness and they are being ventilated and then they get a hospital-acquired pneumonia. That is not COVID. It is not pneumonia, but unexplained pneumonia. If a patient has an unexplained pneumonia, then we may need to consider possible COVID infection. So we need to evaluate our patients with pneumonia very carefully and make a decision. Is this likely to be community acquired or aspiration or hospital acquired? If none of those things are likely, then we consider it an unexplained pneumonia and perhaps consider as a possible COVID patient. Fifth thing is somebody with unexplained respiratory distress. Now, somebody who does not have pneumonia, but somebody who has a respiratory rate of 30, who is tachypneic and whose oxygen saturation, SpO2, will be less than 90. Now, this is a patient with respiratory distress. Again, remember, not all patients with respiratory distress. You must have seen hundreds of patients with asthma who have a respiratory rate of more than 30 and whose SpO2 is less than 90. They don't have COVID. So it is not the routine asthma patients, not the routine COVID, COPD patients, not the routine bronchiectasis patient. But if you see a patient with completely unexplained respiratory distress in terms of low saturation and tachypnea, then you may need to consider the possibility of pneumonia. Again, coming to criteria D, I told you. Now, if you look at the X-rays, now Professor Bodhinayaka gave you detailed descriptions of what the X-ray changes will be. But what is important to remember is, in a COVID pneumonia, it is usually a bilateral pneumonia. COVID patients don't usually get unilateral lobar pneumonias. That is 99% of the time community acquired pneumonia. And if you treat that patient as COVID-19, that patient will die. So we need to treat the patient as a bacterial pneumonia. So important thing is there are 5 groups of patients in whom we make a clinical probable diagnosis of COVID-19 infection. I hope I have made things clear. Herath, may I have the next slide, please? Thank you. And then once you suspect in Sri Lanka on clinical grounds these 5, then you will do it. The patient will undergo laboratory testing to confirm COVID infection. We are very fortunate in Karapitiya. We have probably one of the leading COVID-19 testing laboratories in Sri Lanka. You may have read that so many samples are being sent from so many places in the country to Karapitiya laboratory, virology laboratory, and we test from all over. That is why by mistake recently there was the rumor that 6 patients have been diagnosed in Karapitiya. But what has happened is not our hospital patients. These were positive patients where the samples were sent from some faraway place. So what is the laboratory testing which will help us confirm the presence of COVID? What we do here is PCR testing, polymerase chain reaction. PCR looks for, you will remember from your microbiology teaching, they look for RNA. Now, this is an RNA virus, and RNA or nucleic acids, typical nucleic acids are what are being tested for in a PCR test. PCR tests look for nucleic acids, not for proteins, not for antigens, not for antibodies. To do this test, it's not easy. No one can just walk into Karapitiya and say, hey, I want to check myself with PCR. It is done in Karapitiya, but the patient needs to be admitted either to the isolation ward, where we think that patients are having COVID-19, or there is another ward called the interim ward, where patients who are on quarantine, etc., who have other illnesses are admitted. So these are the 2 places from which in the hospital that we do COVID PCR testing. We also do a few outpatient testing in the OPD in the morning hours, but that is available only during morning hours and to a few patients. Usually, if we suspect somebody to have COVID-19 clinically based on the above criteria, we admit the patient to ward 36, which is the isolation ward, and do the testing. And we look for viral particles. Now, why can't we just do it for everybody? The reason is PCR testing is very complicated. One is, it takes time. It takes about 6 or 7 hours for the test process, maybe up to about 8 hours. So we can do maximum only 3 cycles a day. And in one cycle, usually less than 100 number can be tested. It is an expensive test. It costs, nearly 10,000 rupees for each test. And you need complex machinery, which we have at our hospital. So what I would like you to understand is we can't just be testing everybody who feels like it, because it's a very complicated process. But it is a very good test. There are other tests which have been developed as well. Now, there are antigen tests as well. Antigen detects proteins formed by the virus. Now, there was an antigen test which was made available, and we tested this out in Karapiti as well and IDH to see, but it was not a very specific test. Everything that we tested came positive, and ultimately we tested some tap water and that also came as positive. So at the moment, we don't have a valid antigen test, but it may be available in time to come. And a valid antigen test will be very useful because it can be done very quickly. And unlike PCR, it doesn't have to be done in batches. It can be done for individual patients. Now, antigen testing is usually done under 2 ways. One is an ELISA technique, in which a special machine is needed to read that, or an immunohistochemistry method where it's like a pregnancy test. It's a strip test where visually somebody can look at it and say whether it's positive or negative. So ELISA and immunohistochemistry tests are there for antigens. At the moment in Sri Lanka, we don't have a good enough antigen test, so that is not available. Second thing is antibody tests are also being done. Again, in Sri Lanka, we don't have a good enough antibody test, and antibody tests are not very much encouraged because the antibodies take time to develop, and by the time we get the antibodies positive, that may be too late from a clinical perspective to treat. Of course, from an epidemiological point of view, that might be very useful. And at the moment, what we have are unreliable. So what I want you to remember is, at the moment, our gold standard is PCR. But ultimately, if a good antigen test comes about, that may be very useful because it will be low cost, very quick results, and individual patients can be tested. Then, of course, once we diagnose, then we do certain other tests like Professor Bodhinayaka described to assess severity of illnesses, etc. But I have concentrated within my 10 minutes on when to suspect clinically the 5 groups of patients and how to confirm the diagnosis with laboratory investigations. Herath, I think I've come to the end of my presentation. We can possibly move on to the next one.
Yeah.
Okay.
Thank you, Roshan. Thank you very much for the interesting lecture. So next one, of course, since we had issue with Dr. Champa Vijayasinghe's lecture, we will give the chance to her. She will be talking on global scenario and Sri Lankan scenario. Champa, Champa is there. Can you hear me? Hello, Champa. Can you hear me? Yeah. Champa, you are muted. I think your mic is muted.
Make a muted.
Right. Okay.
Hello.
Yeah, we can hear you. Please go ahead.
Slideshow. Okay. I'm sorry about the introduction that we had earlier. So I will continue from the slide that have been discussing about. This one we have already discussed, the global distribution of the number of cases of COVID-19. And in this picture, you will see the temporal distribution of COVID-19 cases worldwide. That is the plotting of cases against time from 2nd of March until up to yesterday. You can't see the figures clearly here, but what I wanted to show you is the what is called epidemic curve. Those who have completed the lectures in epidemiology will know what epidemic curve is. So you can see that it started off as a small number of cases, but it has escalated, and now it is maintained at a high level. Though the curve is flat, still we have high number of cases worldwide. And this is the geographical distribution of COVID-19 cases within the last 7 days. And the countries with a higher number of cases are marked in a darker color. So you can see that the dark brown is the countries where there are more than 100,000 cases. And then there are some cases, some countries where no reported cases, and in some countries, no reported cases for the last 7 days. And this is for the last 1 week. So you can see where we stand. Sri Lanka, we have about, we are in the region where there are 101 to 1,000 cases. And if you look at the Sri Lankan statistics of COVID-19, up to now we have 925 confirmed cases, of which 439 are currently active. And we have discharged 477 cases, and the total number of deaths is 9, with a death rate of less than 1%. And on your right hand side in this slide, you will see a pictorial representation where you can see that the recovered cases are more than the number of active cases at the moment, at about 52%. This is the epidemic curve for Sri Lanka, which is available from the epidemiology unit website. So you can see that we had a small peak in the middle of March, and from there onwards we have flattened the curve, and now with the recent diagnosis of cases from Kesselwath area and at Palisara Naval Base, the peak has again gone up, and now it's gradually coming down. And this will show you the distribution of cases according to the symptomatic nature. When at the time of diagnosis, you can see that during the initial part of March, most of the cases that we detected were detected through symptoms. They were symptomatic cases. And towards the latter part, most of the cases that we detect are detected during screening, through screening. Those are the ones that are marked in blue. Now you can see that most of the cases that we come across are asymptomatic cases. This is an important factor, because if we have not detected them by screening, they would have been moving about in the community spreading the infection. So this is what you learn as active surveillance in community medicine, where you actively seek patients with disease, in contrast to the passive surveillance where you wait till the patients come to you. So this active surveillance has contributed in bringing down the caseload to a great extent in Sri Lanka. So this diagram is adopted from Sri Lanka COVID-19 coronavirus tracker, and I've used it here because it is an interesting diagram. This shows the total number of cases detected, the active cases and the recovered cases, and deaths across the time span from 9th March up to yesterday. And when you look at this, you can see now we are reaching a stage where the patients who are recovered is rising in contrast to the number of active cases. So the lines are crossing now towards the 15th of March. And this is the geographical distribution of COVID-19 cases in Sri Lanka, again adopted from COVID-19 tracker for Sri Lanka. And the districts marked in dark red or maroon are the ones which report cases, over 50 cases. And you can see that most parts of the country we have between 1 to 10 cases, which I will show you in a little while in a more descriptive table. So in this table, you can see the distribution of cases according to the district of the infected person. The Colombo district reports the highest number of cases at 150, followed by Gampaha, 36 cases, and Putlam, 35 cases. Kalutara also has a higher number of cases at 34, followed by Kandy at 13, and Kurunagala at 11 cases. Most of the other districts have less than 10 cases. If you consider the place of origin of these cases, 489 of the total reported cases were from Navy camps, and 11 cases were reported from other forces. And in quarantine centers, among overseas arrivals, we have detected 45, and among local communities in quarantine sectors, we have detected 67 cases. So that includes all 925 cases that you detected in Sri Lanka. All this information is available from the epidemiology unit situation reports. They give daily situation reports. So if you are interested in finding out the details about the current situation in Sri Lanka, I would suggest you to visit the epidemiology unit website. And a little bit about the transmission status of COVID-19 in Sri Lanka. The World Health Organization has defined 4 transmission scenarios for COVID-19. In the first scenario, it includes countries with no cases. And in the second scenario, it includes countries with 1 or more sporadic cases. That means either imported or locally detected isolated cases. In the third scenario, the countries will experience cases in clusters, either in a particular period of time or a particular geographical location, or maybe due to some common exposure. And the fourth stage is countries that experience large outbreaks due to community transmission of the virus. Fortunately, Sri Lanka is still at the stage of cluster of cases. So the community transmission has not been detected in Sri Lanka so far. So, but we have to be vigilant. Only a single case is sufficient to initiate a community transmission. So we should not let our protection down. And for those who have done your epidemiology lectures, this slide might be familiar to you. You know what this diagram is? It is called epidemiological triad. The 3 key factors that affect the transmission of a disease: the host, agent, environment, and the interaction between this triad. So from 31st December 2019 up to now, by looking at the nature of the disease, the victims or the cases, the researchers have put forward certain hypotheses about the factors that influence these epidemiological characteristics of COVID-19. So they have identified certain host factors, agent factors, and environmental factors that might determine the nature of the spread of disease and the people who get affected. So the agent factors, virulence of the virus is the most important agent factor identified so far. It's a very contagious virus. And among the environment factors, there are hypotheses suggesting that atmospheric temperature and humidity plays a role in disease transmission. If you look at the geographical distribution of the disease, you can see that it is more rapidly spreading in countries in the temperate zone. So this information has led to the hypothesis formation in terms of disease transmission. And population density is also important. Even in Sri Lanka, you may have observed that it is more rapidly spreading in places where the population density is higher, like in this naval base and also in this Keselwatta area. And airflow and ventilation are also other factors in the environment that affect disease transmission. And the most important is the host factors, because that is one place where I can initiate protective measures. So the age of the host has been implicated. The people who are elderly are more susceptible for the disease, and the immunity of the person is also important. Those who have compromised immunity are more susceptible. And underlying health conditions like chronic diseases, you may have observed that most of the deaths that took place, except in one person in Sri Lanka, the persons were suffering from chronic disease conditions. Host behavior, whether you are adhering to sanitation practices, you are doing some kind of risk behaviors like the drug addicts where they share utensils, they have a higher likelihood of contracting the disease. And the number of contacts that you have, and social distancing and community consciousness. If the community is aware and they have these hygienic behaviors, then the likelihood of spreading the disease is less. and the personal hygienic practices like the respiratory hygiene, hand washing practices, they all play a role in spreading the disease. So with that, we come to the end of this presentation. Once again, I thank Dr. Herath for allowing me the chance to join in this seminar. Thank you.
Thank you, Champa. Thank you. Thank you very much for the interesting and very informative lecture. Next one is going to be on treatment, so I'm going to do that. Let me share my screen with you. Right. Can you all hear me? Hello?
Yes, sir, we can hear.
All right, okay. Let's talk about treatment. I'm going to talk to you on Sri Lankan scenario as well as treatment available for COVID-19 globally. Let's talk about Sri Lankan scenario. As Dr. Aroshit Sanayaka talked to you earlier, all the patients who would diagnosed as for COVID-19 would need to get admitted to hospital according to Sri Lankan guidelines. So basically, screening for COVID-19 would happen in community at the moment and also in quarantine centers. And those patients would, if they become positive, those patients would also get admitted. And also there are some COVID screening centers throughout Sri Lanka. Karapiti is one of those COVID treatment centers. Karapiti is one of those COVID treatment centers. As you know, Ward 36, if they're suspected patient with COVID-19, we would admit that patient to Ward 36. And also we have interim ward where we would admit patients who are on, or people who are on quarantine. When they seek for medical advice, for medical or surgical advice for some other illnesses, we would admit those patients to interim ward, and if required, we would do the PCR for them. Once if they are diagnosed with COVID-19, we would send those patients to treatment centers. We have several treatment centers available. We had only one earlier when the epidemic started way back in March. We had only one treatment center that was in Angoda Infectious Disease Hospital. Then there were some other hospitals also opened as treatment centers. We have Mulleriyawa. Then of course we have Homagama COVID Treatment Center. We have Velikanda, and so on. We have several treatment centers like that. And so basically anybody with COVID-19 would get admitted to those hospitals. We would not manage any patient COVID-19 as outpatient. You might aware some other countries, particularly European countries, patients with COVID-19 are managed at home, particularly when they are not very sick. But as you already learned that around 85% or 8 to 85% of the patients have mild illness. Some of them are quite asymptomatic. So when the number of patients are so high, it's difficult to admit all those patients. So countries where the COVID patients are high, such as US, UK, and other European countries, most of the patients with mild illness are managed as outpatient, whereas our patient load is not very high. So almost everybody has to get admitted to COVID treatment center according to Sri Lankan guidelines. Then once we admit, what are we going to do? That is the discussion that I'm going to have. Okay, so what we basically do is we observe them and provide supportive care. Most of the patients at the moment are asymptomatic, where they are just admitted there and observe. And if they have any symptoms, then they would the clinician would attend those patients. Otherwise, they are just observed. And at the moment, all the patients who are symptomatic, symptoms are like fever, sore throat, body aches, vomiting, diarrhea, all those symptoms. If the patient has symptoms, those patients will be treated with hydroxychloroquine as per Sri Lankan guideline, as well as per the clinician who are in the who are in the COVID treatment center. So all the patients who are symptomatic would get treatment with hydroxychloroquine, but those who are not having symptoms, asymptomatic patients, would not get hydroxychloroquine at the moment. And also they would get other supportive care if a patient has hypoxia, or if the patient has dyspnea, those patients would get oxygen, and they will get ventilation if they have persistent hypoxia due to pneumonia. Let's talk about individual medication also. As I said earlier, there are a number of specific therapies available, or at least number of specific therapies tried for COVID-19, out of which hydroxychloroquine and chloroquine are the most famous drugs. Those are antimalarial drugs. Then, of course, we have antiviral agents used for various other illnesses, and also we have convalescent plasma, steroid, and immune modulator. These are the types that have been tried in patients with COVID-19 with various success. Out of which hydroxychloroquine and chloroquine are the most famous and most widely used. These two drugs came into picture because in vitro studies have shown that both HCQ as well as CQ have antiviral activity against SARS-CoV-2. And also a few studies which are done in China, Wuhan province, showed promising results. As a result, Chinese government came out in news briefing and mentioned that both hydroxychloroquine and chloroquine are effective against COVID-19. With that, there is great interest on hydroxychloroquine and chloroquine, and therefore most of the countries, it became the standard treatment, even though there were no clinical trials showing the significant benefit of these agents. Subsequent to that, there were many studies done to find out the effectiveness of hydroxychloroquine as well as chloroquine on COVID-19 patients, but none of those studies showed any significant benefit. So at the moment, what we had is just a conflicting evidence. Few studies which are primarily done in China showing the benefit, but the studies which are done outside Europe as well as America showing no benefit at all. And there's a study which was published 2 days back in BMJ, which was done in China, again showed no benefit. So at the moment, what I can say is HCQ as well as CQ had no significant benefit against COVID-19, even though we are using at the moment for symptomatic patients. And also some of the patients can get serious side effects such as long QT syndrome, and some of the patients can get symptoms such as diarrhea. However, HCQ is the only drug which is recommended by the Ministry of Health Sri Lanka for patients with COVID-19. According to ministry guideline, anybody with COVID-19 should be treated with HCQ irrespective of their symptoms. But anyway, we don't follow the ministry guideline. At the moment, only those patients who have symptoms of COVID-19 would get treatment with HCQ at present. Right. Then antiviral agents. There are several antiviral agents which have been used against COVID-19, of which remdesivir is the most famous one. I think you all must have heard about remdesivir. Remdesivir is one of the antiviral agents which was tried against Ebola. But anyway, there were a few clinical studies done against COVID-19, and there was some benefit of remdesivir. There's a large clinical study which was conducted by US NIH, National Institute of Health, and this particular study showed that remdesivir reduced the length of hospital stay. It does not reduce the mortality, but it reduced the hospital stay. So at the moment, it can be used for severe patients who have severe illness, who are on ICU care. It can be used, but it's not available in Sri Lanka, but available in other countries. But again, it seems that it does not have any mortality benefit. Then lopinavir and ritonavir are two agents which have been used primarily as HIV medication. So there are in vitro evidence showing benefit of lopinavir ritonavir in combination against COVID-19, and there were a few studies also showed some clinical benefit, but again, overall, we don't know whether these agents are effective or not. Then your famous Avigan, one of the flu drug which is available in Japan, which is called favipiravir, which also had been tried for COVID-19, but unfortunately, there is no evidence found at all. Oseltamivir is one of the anti-flu agent available in Sri Lanka, but again, none of the studies have shown any beneficial effects. So out of antiviral agent, remdesivir and lopinavir and ritonavir are the agents which had shown some benefit, but others benefit. There are no benefits at all, and in general, those agents are not used against COVID-19. There is a famous study called the WHO conducted a famous study called Solidarity study. Basically, there are 4 arms in this particular study. One of the arms is lopinavir, ritonavir, and also HCQ also used in one arm, and also lopinavir, ritonavir also used in one arm. So still the results are not out. So once the results are available, we know which of the agents are effective against COVID-19. So at the moment, what I can say is probably remdesivir has some benefit, particularly in reducing the hospital stay. Lopinavir and ritonavir, probably the benefits are not great, and we need further studies to see whether it's effective or not. Then, of course, convalescent plasma. You might have heard in the TV that the first patient from Mattegoda was readmitted to get plasma from him to administer to other patient who is critically unwell. This is called convalescent plasma. Convalescent plasma is plasma taken from people who recovered, and these plasma are administered to patients who are quite sick. Basis is that those people who recovered from COVID-19 have antibodies against COVID-19 virus, SARS-CoV-2, and then those antibodies can neutralize the effect of virus. That was the basis. However, no solid evidence support this theory. And this convalescent plasma has been tried in many countries with various success. Again, there is no solid evidence to say that this is very effective, but most of the time this is being used as a compassionate drug. Compassionate means there is no other thing to do. Basically, you try this one. So that is convalescent plasma. Then, of course, we have anti-immune modulators such as tocilizumab. During the presentation of Professor Bodhinayaka, she said that COVID-19 there is cytokine storm. One of the problems why some of the patients can deteriorate is because of the excessive cytokine production causing various damage. So it has been found that if these cytokines can be blocked, probably the effect can be minimized to some extent. So that was the theory. Tocilizumab is an immune modulator and basically blocks the interleukin-6. So this has been tried in COVID-19 small studies, and again the benefits are not great, and the evidence are quite conflicting. So at the moment, it's not used as a specific drug, but it might be used as a compassionate ground for some patients, particularly those who are critically unwell. Then other agents that have been tried are steroids. Steroids are generally not recommended for patients with COVID-19 unless they have severe acute respiratory distress requiring intubation. And one thing, of course, I want to tell you about non-invasive ventilation. So non-invasive ventilation is discouraged in patients with COVID-19. It's primarily because when you do non-invasive ventilation, it can basically enhance the airborne situation, because COVID-19 spread as a droplet infection. But when you do non-invasive ventilation, because of the pressure effects, the disease can spread as an airborne disease. So that is one reason. And also when you give NIV, studies have shown, at least there is some theory that it can increase the lung injury. So therefore, non-invasive ventilation is not generally been used for COVID-19 patient. Instead, intubation, or when the patient persists in hypoxia despite on oxygen, if the patient cannot be managed with oxygen, generally the next step is to intubate the patient and manage the patient in a prone position. That is called prone ventilation. Intravenous antibiotics are used for COVID-19 patients, because sometimes these patients can get infected with bacterial infection also. Therefore, when a patient with COVID-19 gets severe pneumonia requiring hospital admission and intubation, those patients would get intravenous antibiotics also commonly. So, so in summary, at present, all COVID-19 patients need hospital admission to COVID treatment center, and no specific treatment is found to be effective. And at the moment, I think the only drug which has shown some promise is remdesivir, which is one of the antiviral agents. And even though HCQ is recommended in Sri Lanka, it is not found to be effective in most of the studies. Right, thank you. With that, I would ask Dr. Gaya Wijayaratne to deliver his lecture. I think Gaya is there. Dr. Gaya Wijayaratne will be talking to us on precaution action for COVID-19 prevention. Over to you, Gaya.
Thank you very much, Dr. Herath. Can you hear me?
Yeah, we can hear you.
Right. Okay, so first of all, I would like to thank you for organizing this and giving us the opportunity to share our knowledge on this. Since you have gathered a lot of knowledge on COVID, I'll straight away start on infection prevention and control part of COVID-19. As we already gathered knowledge about this, we know that very limited data on treatment. So what we have to depend on is mainly the preventive aspect. When compared with many other infections, where they have drugs or vaccines to prevent, in the case of COVID-19, so far, there's no evidence for a proper chemoprophylaxis or a vaccine to prevent from this disease. So there are many studies going on, but at the moment, we don't have any of these measures. Because of that, we have to stick to the infection prevention and control measures. So we have to prevent the transmission of the disease and prevent us being exposed to the disease. For that, there are key things we have to adhere to. To start with, the main thing is to wash our hands with soap and water. If not, we have to disinfect our hands frequently with a hand sanitizer, that is alcohol-based hand rub. Also, we should maintain adequate social distancing. It is recommended at minimum of 1 meter, or some guidelines 2 meters. And we have to maintain respiratory precautions, including cough etiquette and wearing masks. And also we have to minimize our movements. When we adhere to these measures, we should always keep an eye on our health. If you get the slightest information or the feeling of developing symptoms suggestive of COVID-19, you have to seek medical care. So it's being discussed in previous presentations. So what are the symptoms you have to think of? So now we'll come to the situation of a medical student, how we apply these to a medical student. First of all, a medical student, a preclinical student who will not go to hospital, they will mainly stay in the faculty. In the evening, they go to the hostel or home, and they will travel in the road in between. So what are the measures they have to take? So this category of medical students, they have to wear a mask. At this, ordinary cloth mask will be adequate because they are not exposed into the hospital setup. When wearing a mask, you should remember you have to cover both nose and the mouth. That's from the bridge of the nose to the below your chin. When you're wearing any kind of a mask, a cloth mask or a surgical mask or a different one, you have to make sure not to touch or adjust the mask once you wear it. Also, you should not remove it even temporarily. If you are wearing, you have to wear it throughout. And also, do not touch your face or eyes with your bare hand. If it is a cloth mask, at the end of the day, you can wash and reuse it. Until you wash it, you have to collect it into a separate bag. Then you have to maintain the hand washing as frequent as possible with soap and water, and always try to keep the distance. And you have to avoid unnecessary exposure or travel. If it is only essential, you go out and go for that, or else you stay at one place. So that's emphasized by quarantine. And if you want to attend to work, group work or discussions, the number of people should be less than 5, and you have to always keep to the recommended distance and the precautions. We recommend to do self-studies as much as possible during this critical period. In the evening, when you are returning to hostel or home, make sure to leave your shoes outside the room or house. And if you are wearing a surgical mask, you have to discard at the entry to the house or the hostel the proper way into a designated bin, and this bin should be discarded appropriately. Then you have to wash your hands with soap and water and remove your clothes and place them in a separate bag until they are washed. Best if you can wash it daily. Then you have to have a shower or a wash before you do anything else. Then the second scenario, a medical student who will be going to the hospital to see the patients and to do the clinicals. In this case, you have to have a better protection, so you must wear a surgical mask. The surgical mask, you have to wear it the proper way. So in the first picture, you may have seen there are 2 people wearing it. The first person wears it proper way, because the mask has 2 sides, one side the blue one and the other one the white side. The correct way is you have to wear the blue side towards outside, because it's the impermeable layer. And all the other measures are applicable while you are wearing this mask. And also make sure in the bottom picture that you covered adequately from the bridge of the nose to below the chin area. And also once you wear this mask, there's a small strip for the nasal bridge. You have to press it and adjust it according to your nasal bridge. As this surgical mask can collect infectious material more than the cloth mask, you should dispose it according to the recommended way into the biological waste. You have to always maintain hand washing with soap and water. If not, use alcohol hand rubs. And I recommend you to have your own alcohol hand rub in your pocket. Then while you are in the hospital, you must wear a lab coat. So when you are coming out from the hospital, you remove it and keep it in a separate bag. And when entering the faculty, you have to wash your hands with soap and water and keep this lab coat in your locker until you finish your rest of the work in the faculty. And when you are going home or to the hostel, take it in the separate bag for washing. And it is recommended to wash as frequently as possible. Even in the hospital, try to maintain the distance. Then make sure to take minimum number of items to the wards or to the hospital. Don't carry a bag. Don't carry a lot of books with you. Take minimum number of things which can accommodate your pockets in the coat. Do not wear any jewelry or ornaments. Do not carry a handkerchief. It's best to avoid the mobile phone, but if you want to carry it, make sure to disinfect with alcohol before you return from the hospital. Keep your pens for yourself and avoid unnecessary exposure while you are in the hospital. Do not lean to the beds, furniture, or to the walls. Do not touch surfaces. And even you do it, make sure to wash your hands as soon as possible. So while you are in the hospital, you may have to examine or take histories from patients with respiratory symptoms. So before you do that, make sure always whether the patient wears a mask. So patient should be wearing a mask, and then you can approach with a surgical mask and with your lab coat. If you are examining the patient, please wear a pair of disposable gloves and make sure to discard it as soon as you finish in the procedure or the examination, and to wash your hands immediately after. If you keep it wearing throughout your hospital stay, you will continue to contaminate your books, pens, PhDs, and the other surroundings with your gloved hand. So don't do it. And when examining these patients, always try to keep the distance and minimize the contact time as much as possible. In this group of patients, if you happen to do a procedure, and if it is an aerosol generating procedure, you must take additional precautions. So these procedures may, as mentioned by the other lectures, nebulization, intubation, bronchoscopy, or most of the dental and ENT procedures, where you have to wear a special mask called N95 mask. Then you have to wear either a face shield or a goggle to prevent splashes onto your face and to your eyes, and a pair of gloves to protect your hands. And also a disposable gown made of impermeable material over your lab coat. Soon after the procedure, make sure to get rid of all these PPE immediately and to wash your hands. And when you are wearing as well as removing these PPE, adhere to the correct protocol that will minimize the self-contamination. So I think I have briefed the basic precautions you could take to protect yourself. You have to know, as healthcare workers, we are at high risk of exposure to any kind of infectious disease. Therefore, we cannot hide or run away from these. We have to manage these patients, but without infecting ourselves or without spreading the disease among ourselves. Therefore, to achieve this, always adhere to infection prevention and control measures that we have summarized here. Thank you.
Thank you, Gaya. Thank you very much. The next one is on COVID-19 in children. Aruna, are you there? Yes, Dr. Aruna is not connected yet. I think we will ask Dr. Lanka Dasanayaka to present his lecture that is on COVID-19 pregnancy.
Hello, can you hear me here?
Yeah, Aruna, yeah, please, yeah. Yeah, we can hear you, Aruna.
Can you see the screen? The slides there?
Now we can't see your screen. If you want, I can share your screen if you want. All right, we can see you. Yeah, can you go to the view mode, please?
Is it there now?
Yeah, we can see your slide. Yeah, please go ahead.
Okay. Thank you, Herat, for organizing this and inviting me to talk on this topic. And I think most of the things that I'm going to tell today is previously spoken, but a little bit specific for children. I would talk on the same sort of topics. Well, there are lots of articles and guidelines about COVID-19 in children, but I thought this would be the most appropriate and needed article for the management of children in Sri Lanka for COVID-19, which is published by the Sri Lanka College of Pediatricians. It's called the Clinical Practice Guidelines on the Management of Children with Suspected or Confirmed COVID-19, which was issued in 31st of March 2020. And I have got some data from 2 recent journal articles as well. As much as adults, children of all ages from 1 day of age appear to be susceptible to COVID-19. There's no significant gender difference in children with COVID-19 that has been seen worldwide. Children with chronic lung disease or other comorbidities, like in adults, has a higher risk than other children, and very young population are particularly at risk. What is good about COVID-19 in children? Everybody says that children are having less severe infection. So these are hypothetical things and some of the data from the world. According to the available data, the total reported cases worldwide aged less than 18 years seems to be less than 5% of the total number of cases. So we have a lesser percentage in our population compared to all the cases. In Sri Lanka, according to the Ministry of Health data, by 15th of May 2020, out of 925 total patients, only 78 patients were there in the category of less than 18 years of age, which is 8.4%. And most of them were in between the age groups of 15 to 18 rather than the younger ones. In contrast to infected adults, most of the infected children appear to have a milder clinical course. Fourthly, the number of reported deaths among children due to COVID-19 is also remarkably low. For example, only 2 being reported in China up to the 30th of March 2020. According to this article, which was published in March 2020 in Acta Pediatrica, why is COVID-19 so mild in children? These are all hypothetical ideas and not confirmed scientifically, and the proposed reasons for mechanisms for milder disease and less number of pediatric cases due to COVID-19. Firstly, fewer opportunities for exposure than adults due to various factors, such as school vacation time and less exposure in infants who naturally stay at home. Of course, children does not go out as much as adults. Secondly, the relatively immature immune system, which leads to less severe adverse inflammatory response to the virus. Of course, we heard that most of the severe patients, the main problem is the inflammatory cascade. Thirdly, the relatively less developed number, maturity, and the function of the angiotensin converting enzyme 2 receptors in children. We all heard that this is the receptor to which the virus gets attached to secure entry into the cells in the respiratory system. Fourthly, the likely cross-reactivity of antibodies against other coronaviruses with SARS-CoV-2 virus, as children are likely to have more infections compared to adults. Clinical case definition of COVID-19 in children, which I'm not going to discuss because Dr. Arosha Disanayaka discussed in detail, and the same things apply to children as well. Transmission, as discussed earlier, it is primarily by respiratory droplets, but viral shedding has been demonstrated in stools of patients with COVID-19, but a definite evidence of fecal transmission is lacking. This is important in children because children present with diarrhea, and people might think that this might be a cause for transmission or disease, but it is not been confirmed. There's no strong evidence to support the vertical transmission of this virus from a pregnant mother to her fetus. You all would have heard that there was a news item saying that newborn on day 1 has been infected with corona, but this is later on found that the IgM was positive, but the PCR was negative. So this is probably the transmission of antibodies from the mother rather than the child getting the infection itself. There's no evidence to support viral transmission through breast milk as well so far. Let's go on to the vulnerable groups of children for severe or complicated disease. As in adults, any underlying significant chronic respiratory conditions, especially in children, conditions like chronic lung disease of prematurity, cystic fibrosis, and primary ciliary dyskinesia, etc., are children with those conditions are very vulnerable. Severe or uncontrolled asthma, respiratory complications due to neurological or neuromuscular disorders, such as cerebral palsy, immunocompromised states, and primary immunodeficiencies, those who are on treatment for malignancies, post-transplant patients, asthenia patients, either functional or surgical, hemodynamically significant cyanotic or cyanotic heart diseases, patients with chronic kidney diseases at stages 4 or 5, those who are on dialysis, and also severe malnutrition are taken as vulnerable groups of children for severe or complicated diseases. According to the ages, only few studies been done. According to a case series of 2,143 patients in China, this graph shows the severe and critical cases, the percentage of severe and critical cases. And you can see that the highest number of severe and critical cases out of our pediatric population is mainly the less than 1 year group. The diagnosis testing criteria for children are the same as for adults at the moment. Depending on the presence of symptoms, travel history, contact history with a confirmed COVID-19 patient, or if there is a need to rule out unexplained pneumonia without a positive contact history, a diagnostic test is indicated. Now, there had been conflicts whom to diagnose whether exactly this patient has got COVID. It is recommended by the College of Pediatricians that the final decision should be made by the specialist consultant pediatrician in charge of the case regarding the patient. Now let's talk about the differential diagnosis in our population. The influenza, parainfluenza, adeno, respiratory syncytial virus, the rhino, human metapneumovirus, mycoplasma pneumonia. You all know that this is pretty common in school children. Chlamydia pneumonia are the commonest differential diagnoses that we would entertain. With regard to the investigations, as mentioned earlier, chest imaging will show lobar or multilobar, bilateral, mainly Pesci consolidations, laboratory findings of leukopenia and lymphocytopenia. Platelets will show a thrombocytopenia in severe cases. The CRP might be normal or elevated with a procalcitonin level elevated. Elevated transaminases and elevated D dimers are seen in severe. So you can understand that most of these things, in fact, all of them are very non-specific things. So ultimate diagnosis is by PCR. Now regarding the management, I think Dr. Hira discussed about the management. In most of the children could be managed with bed rest and supportive measures. Anyway, the adequate hydration and nutrition is of utmost importance. But a restrictive fluid management is recommended in severe cases to avoid SIADH. What about continuation of breastfeeding? So if the baby has got COVID-19, the maximum protections should be taken to prevention of transmission it to the mother and vice versa as well. Of course, we all know that antipyretics and analgesics such as paracetamol has to be given. Monitoring of these patients are important to identify hypoxia and systemic involvement. Repeated investigations are needed. And sometimes bronchodilators are needed, not routinely, but if required, it is important to remember routine nebulization is not recommended, and the preferred is MDIs with either a face mask or just a spacer to prevent aerosol droplet transmission. Supportive oxygen therapy and early identification of hypoxia and prompt supply of oxygen is needed. And if the child needs ICU care, it should be an elective ICU care transfer rather than an immediate or urgent transfer at a latter part of illness. Further respiratory support from our college, we have recommended heated, humidified, high flow nasal cannula oxygen. But I think we have never required this sort of management because our patients have been so far not critically ill. Worsening hypercapnia, acidemia, respiratory fatigue, hemodynamic instability, or those with altered mental status should consider for early elective invasive mechanical ventilation. Again, it is elective rather than urgent or immediate. Children who are on AC inhibitors, there is a potential risk of severe disease due to possible upregulation of the number of AC receptors, and the clinicians should keep this in mind. Now, all the following criteria should be fulfilled for discharge. The child should be afebrile for at least 3 days. A significant improvement in respiratory symptoms should be there. A progressive improvement of chest imaging findings, which suggests resorption of the inflammation. 2 consecutive negative PCR tests of respiratory samples, which have been done at least 24 hours apart. And although all these things are there, it is recommended recovered children should be home quarantined for another 2 to 3 weeks following the discharge from the hospital. Now, this is the most recent one, which was from the 8th of May 2020, the novel inflammatory syndrome in children possibly linked to COVID-19. Now, there's lots of patients and lots of information coming from the West and America, US, that patients who are positive for COVID-19 presents with a feature suggestive of Kawasaki disease. We all know what Kawasaki disease is, a very dangerous condition with 5 main criteria to diagnose. And there's a condition called atypical Kawasaki, where you might not have all the criteria to diagnose. And also conditions which we call toxic shock syndrome may be associated, and maybe these patients present with features suggestive of these conditions. So in our setup, although they do not have all the contact history and the travel history or other features of COVID, if a patient presents with Kawasaki and toxic shock syndrome or atypical Kawasaki, we might rethink whether this is really that or it is associated with COVID-19, and we might investigate in that part as well. Thank you very much.
Thank you, Arna. Thank you very much for your very informative lecture. Next, I would invite Dr. Lanka Dasanayak to deliver his lecture on COVID-19 in pregnancy. Thank you, Lanka.
Thank you, Dr. Hira. Let me to share the screen. Good morning, everybody. Can you hear me? Dr. Hira, can you?
Yes, we can hear you. Please go ahead.
Okay,
We can hear you.
Good morning, everybody. So, first of all, thank you, Medicine Department, and especially Dr. Hira, for organizing this important lecture series about the coronavirus and giving me the opportunity to discuss about the pregnancy and coronavirus. So at the moment, I know that this is maybe the last lecture, but up to now, so most of the things, pathophysiology, symptomatology, and treatment, pediatric enrollment, everything discussed. So this is a special category of the patients' pregnancy. So I'm going to discuss in brief, so what is the situation at the moment in pregnancy. So what we know is the pregnancy is a special physiological situation with the altered immunity and other lot of physiological changes happening. So because of that, so we categorize the pregnancy as a special situation. So and any infection during pregnancy may have in different severities. Sometimes it may be a kind of involvement with the lot of matter morbidity and mortality. At the same time, we are concerned about the other obstetric outcomes. So I may discuss in my next slide. And there's a concern regarding the vertical transmission, that is during intrauterine life, the mother to baby, and at the time of delivery. So then we have to talk about the antenatal, intrapartum care, postpartum care, and the newborn care, especially with regards to breastfeeding. But what we have to appreciate currently there's the limited evidence to say definitive mode of things with the limited evidence. So the recommendation based on the limited evidence. Most are from the cases and case series and expert opinion. Any pregnant woman getting pneumonia in general, so there are concerns about their disease outcome. So usually this virus mainly causing the condition called pneumonia, lung involvement. So any lung involvement during pregnancy has a concern like both bacterial or viral infection. The important causes for morbidity and mortality. The 25% of women require hospital admission, but in our part, so everybody will get the hospital admission. So there is a higher case fertility rate than non-pregnant women with the pneumonia. So at the same time, there are other obstetric outcomes, as I discussed earlier, associated with pneumonia. So those are the preterm pre-labor rupture of membrane, preterm labor, intrauterine fetal death, and growth restriction. Following delivery, there is a chance that newborn baby to have neonatal death or related complication and prematurity related complications. So this is the comparison of the study done up to now. The world literature says the important studies, especially we have to concern about the WHO study involving 64 cases. Other studies involving small number of cases. Here what we can see is the maternal outcome with regards to ICU admission is almost zero in the most of the studies, but few studies shows some percentages, but those involve the small case series. And the maternal mortality, there are a few maternal mortality around the world, but those are not directly related to this virus. But most case series shows zero maternal mortality. And pregnancy outcome per se, there are some case shows increased miscarriage and intrauterine fetal death and preterm labor, but which are in large series of study like WHO series shows there are no adverse pregnancy outcomes. Most of the babies delivered healthy. So we have to pass the key message to the pregnant woman. So generally we can reassure them. We can offer reassurance because they are not having, not more likely to get infected than general population. That means so even though their immunity is altered in the body, but the infection rate is more or less similar to the general population. And they are also less, not more likely to get severe kind of infection when we compare to general population. So vast majority of the pregnant women are having good fetal outcomes. That's mean what we discussed with the disease like a pneumonia, the preterm labor, pre-labor rupture of membrane, intrauterine fetal death. So those are not observed in a significant number. So up to now, there are no evidence to say the teratogenicity of the virus, but in future, so the follow-up cases, so we have to see whether there is any evidence to see teratogenicity. So then we have to discuss about the intrapartum management of pregnant women with a suspected or confirmed COVID-19. So we know that this is spread by the droplets. So as Dr. Daya said, wearing face mask, eye shield, gowns and gloves are important, especially for the healthcare workers to protect from the infection. So in case of aerosol generating procedures, that means any surgeries for the pregnant woman done under general anesthesia is high risk, needing intubation. So the healthcare worker should use N95 mask. In cesarean section, it is usually done under spinal anesthesia. In that case, N95 mask is not necessarily important, but you have to use a full PPE. During labor, normal labor process, intrapartum fetal monitoring is recommended with continuous fetal CTG, because we consider this as a high risk condition to detect the fetal distress and then subsequent management in case of fetal distress. Mode of delivery is depend on the obstetric indication, but the infection per se not necessarily is indicated cesarean section for these pregnant mothers. Spinal anesthesia can be given, is not competitive. Most of the cases, that means if you can do the cesarean section by spinal anesthesia, that is the most safest the way of anesthesia, because if you are going to give general anesthesia, so there is a high risk of generating droplets, so then it can infect the healthcare workers. So you know that after delivery of the baby, so we manage the third stage of labor with a delayed cord clamping. But so in third stage management, there is no evidence up to now to avoid delayed cord clamping. So you can manage the same way with the delayed cord clamping, the control cord traction, and IV oxytocin. So at the time of a birth, so infant should be checked for the COVID-19 virus. So then the neonatology team should be informed. They should take the samples and send off for the testing of the newborn baby. So what about the vertical transmission? So there are no documented cases of vertical transmission up to now with the SARS and other viruses as well as the COVID, because they have checked with the in small cases, they have checked the cord blood for the virus in newborn babies. They couldn't detect any viruses in the newborn babies. So at the same time, so breast milk, with regard to breast milk, so there's no, up to now, there is no evidence to say that it will secrete by the breast milk. So mother can involve the breastfeeding with the use of precautions to prevent the transmission of the disease mother to baby after birth. So they have to use different technique, and if a mother is infected with this disease, so they are in the face mask, and then the washing hands, and after feeding, separating the baby is other precautions they can take. So postpartum management, still the evidence are limited. There is no recommendation to isolate the baby from the mother. They can continue breastfeeding, but all the precautions of the transmission to mother to baby should be followed during postpartum period. Yeah, thank you. So those are the management options in pregnancy and COVID. In summary, so what I have discussed up to now is there is no high chance of pregnant mothers getting the disease, so we can reassure mother. And so there is no high chance likely to be getting severe morbidity with the general when we compare with the general population of pregnant mothers. And there is no evidence to say the vertical transmission or the transmission of the infection to the baby, particularly the postpartum management, there's no recommendation to isolate the baby. And at the same time, what I have to say about the Sri Lankan scenario, so I have contacted the Colombo East Teaching Hospital, where the pregnant mothers, confirmed pregnant mothers are managed in Sri Lanka. That is the assigned center. Up to now, we have 6 pregnant mothers infected with COVID-19. So all mothers transferred to Mulleria Hospital, Colombo East Teaching Hospital, and one mother had a false positive test, and one mother had a on admission intrauterine fetal death. That is totally different, different scenario. That is most probably that death happened due to placental abruption. Up to now, no maternal death or severe maternal morbidity.
I'm here. Okay.
Mild kind of infection with a dry cough and fever. The fetal outcome, except that fetal intrauterine fetal death, other neonatal outcomes are absolutely fine up to now. That is a Sri Lankan scenario. Thank you.
Thank you, Dr. Dasanayakar. Lanka, thank you very much for your very informative lecture. The next one is on what does the future hold post COVID-19. The next lecture will be delivered by Professor Lekam Vasam. So are you there?
Yes, sir, I'm here.
All right, sir.
Can you hear me?
Yes, sir.
Okay, right. Okay, so let me share the screen first.
Okay, thank you, sir.
Okay. The screen. Can you see that here?
It's going to, yeah, we can see it, sir.
All right, okay.
Right, thank you.
Okay, first of all,
can you go to the view mode, sir?
Can I go to the Zoom mode?
View mode, yeah, view mode, yeah.
Yeah.
Right, yeah, that's fine, yeah. Please.
Okay.
Still it's not in view mode.
Okay, is that okay?
It's okay, so if you go to slideshow, you should be able to do presentation mode.
Slideshow, is that okay?
Yeah, that's fine, sir. Yeah.
Okay, okay. So good morning, everybody. Still good morning, isn't it? Okay. Good morning, and thank you very much for giving me this chance. And I believe the people must be a little tired by now, is it? No? Hello?
Yeah, we can hear you, sir.
Yeah, okay. So this is like a one-day match, really, cricket match, isn't it? The last man doesn't have to do very much, really, because what needs to be said is already been said. So I have very little to do. And also that one of the advantages I found in the topic that we given to me is that everything said before me, if somebody want to go and cross-check, then they can do that. Okay. So when Professor Bodhinaka said about, clinical features, and then Professor Arashazana said about the investigation and all, and somebody go to the web page and then check whether they are accurate or not. But only thing, I have got an advantage that no one will be able to check whether what I'm going to say correct or not, and until another 10 years or so. So it's a bit of advantage. Okay, so what the future holds for COVID-19 is no one knows. That is for speculation. But we know that the world is not going to be the same and this post-COVID period. People have already predicted there will be a huge economic downturn globally and as well as at the country level. So many countries will not be able to resist this economic downturn, which is going to happen global wise, and then they are going to be a part of that economic downturn. The economic downturn is going to be so grave that some countries face the risk of bankruptcy. And already some countries are raised their concern, and International Monetary Fund and various stakeholders in that matter sort of, raised concern about certain countries, which of course had a shaky economy. And these are not small nations really, what we are talking about, some of the even big nations, and where they had a little bit of shaky economy before the COVID-19, and now facing a huge threat of this. Now, certain companies like big players in the share market and all will certainly disappear from this world. And we know that, after 9/11 incident, and certain American companies just disappeared on the next day. And likewise, certain big players like big companies and certainly will struggle to survive, and they face the threat that, they may disappear from this world. Are you still hear me? Are you?
Yeah, we can.
Hello?
Yeah, go
okay,
ahead, sir.
Okay, right. Now, in fact, I mean, just one thing that I learned during the recent past is that the most of the economists predict that the countries which recover fast and will have a chance of survival in this economic downturn. And that is why some countries like China and Sri Lanka is struggling to get back to normalcy as early as possible, because then they can be in the economic sort of, the market. And while some countries are having sort of, the infection going on. So countries which recover has a chance of, recovering early from this economic downturn. And also people have speculated that there will be an equilibrium in the world power. We know that, certainly the world power is highly polarized. On one hand, we got the USA, and on the other hand, we find the, Russia on the other hand, and the China coming up and this and that. And then we know that the world power is actually in the hands of few nations and not certainly in the Asia. But then the people predict that in years to come, and the Asia would be would play a dominant role in deciding the world power. So I'm not saying that, it's my wish, but again, I'm not saying that the Sri Lanka will be sort of, will be sort of leading the world or something like that. But certainly Asia as a whole, and with the huge population it has, it's also wealth, and then it will be sort of, countable in new equilibrium. And after this post-COVID, when we sort of, really look at these things. And also people feel that, that people will get close to the nature. And we knew that because when the curfew was, we have the long lockdown, and what we could do is we get back to our gardens, which we had never visited for years and years. And also I know most of the people, they got back to their garden and did some, grew some vegetables. And then, that they get a chance to get into close to the nature. And then when you say getting close to nature, it's not really this. And I'm sure the people who have traveled to China may have seen this, what's called the wet market, and where you can get anything under the sun, any animal. And one day I was walking in between a couple of those shops, and then suddenly frog leap out of just in front of me, huge one. Must be about at least 1 or 2 kilos or something like that. I don't know where they grow them. And then you can get anything like a reptile and the frogs and the bats, you name anything, and you can get in those wet markets. So when I say people getting close to nature, and I certainly don't mean that they're trying to do something like that. What probably people will need to do that, get back to your family and protect your nature. And people say that, certainly this happened as a result of the equilibrium between the nature and the human behavior. Now, this is really hilarious when you see this. Now, the USA declared on 19th of March saying that they put that the whole country in the war footing, and saying that we got a war to fight. But then, this innocent fellow, he has got so many missiles and the rockets and everything in his possession, but can't fire a single one of those, against the virus. So then suddenly people realize, what have you been doing? You have been, making missiles and the rockets and this and that. And then the virus came, and it took the entire world into their knees. And no one can say like, we are not afraid of this now. Hello? Hello?
Yes, sir. We can hear you.
Yeah, okay. So no one can say, no country or no individual can say that we were not afraid really, because, you know, at the initial stage, we all were worried, but now we get a clear picture because in a given geographical location, the virus seems to survive only for a certain period. In the first wave, I don't know whether we're going to get a second wave, third wave, like, you know, a Spanish flu pandemic, but then in the first wave, we have a feeling that, you know, I mean, it lasts only certain period in one geographical location before it sort of moves into another geographical location, like, you know, marching from China to USA, like, you know, like those. So epicenter keep on moving. Now, if you remember not remember, you know, if you heard about what's called post-Spanish flu, which happened in 1918, and of course, many reforms took place afterwards. If you read the literature, and what they say is that at that time, the healthcare was completely fragmented, and the doctors were paid by, let's say, charities and by churches. And if you really go and see the numbers that, you know, like, you know, let's say IDF hospital had so many patients admitted, what they say during the Spanish flu, St. Paul's Cathedral had this number of patients admitted and this number of deaths. That means that the church or the cathedral was where the doctors were employed. So they were basically paid by the charity and also by that kind of, you know, organization, social organization. So there was no organized healthcare system as such at the time the Spanish flu came in 1918. So obviously there was no national coordination like Minister of Health and blah, blah, blah. And also, but there was a WHO because it was formed before that. Now, one of the major problems is that what is called, there was no notification of diseases at that time. And it took a long time for the people to realize that it was a virus, because people thought at the beginning that they have got what is called the God is going to punish them. You know, there's a way the God punished them. And they probably had that idea for a long time. And before they sort of, you know, look for an organism causing the illness. And it took a very long time for them to sort of, you know, realize that it was a viral infection, and also took a long time to realize, you know, what kind of virus it was. So they had no idea about the size of the virus and what measures would sort of, you know, prevent the spreading of that virus, and what kind of mask would prevent entry of that virus into somebody's upper respiratory tract. So I had no obvious idea about any of those. Obviously, they didn't have screening methods, they didn't have treatment, and there was no vaccination. So when the Spanish flu came, that completely got the whole world in surprise. And where the fragmented healthcare systems at that world was never able to sort of, you know, handle this. So as a result, what people say is more than 50 million people got wiped out. And then it amounts something like a 2.5% of the global population. And some of the countries in Alaska and all, you know, completely and wiped off humankind. And then there were no survivors on those countries after Spanish flu. It third wave, you know, it came in three waves. Now, the idea of what is called the socialized medicine, and that is where the healthcare for all, free at the point of delivery, came after the Spanish flu. And the people thought about this, they had to have some kind of coordinated system of delivering health to people, and then the WHO sort of coordinated. And the first country on the record, say first country with this concept was Russia. Russia sort of, you know, first established what's called the Ministry of Health, or the equivalent of that. And then, you know, that they developed the healthcare system. And then, of course, the British, Europe, and then other countries, the Asian countries, they established what is called healthcare system. And then that, you know, some countries made it free, some countries part free. But then the difference came from the USA. And the USA never believed in this what's called the socialized medicine concept. And they thought that, you know, it should be a commodity. The health should come as a commodity and people had to pay for it. And then what they say is that who's going to pay for it? And then, you know, they thought that the patient has to pay for it. And then probably they will have to think twice about it, that, you know, once when they go past this pandemic, how they're going to shape in their healthcare system. Now, look at the little different components of the post-COVID, and then look at the higher education. As you know, there are many transformations happening in health education, like, you know, what's happening now. And any other day we'll be facing you all and delivering this lecture. And then there we find that half of the people are sleeping, but there's no way to find whether 70%, 90% people are sleeping or not. There's no way to find it now anyway. So these are what are called the transformation in health education. Now, teaching delivery methods is going to change. Now, there's a possibility that the courses like, study programs or the lecture is the only mode of teaching. For example, take something like a management and then or humanities. And there's a possibility that you can convert this to what are called distant learning programs. And you don't have to bring about, let's say, 400 management students to Rohana University, give them accommodation and then the Attale fight and this and that. And whether you can convert them to a distant learning program, I'm sure you can, because that's basically they depend on the lectures and not anything else. And also that in medicine, and there are what's called the science-based study programs, and where there's anything more than lectures like practicals and the tutorials, blah blah blah. And then you can perhaps have the lectures during the weekend and then during the night, and then you can cut down the duration. And one of the senior academic from Colombo Medical Faculty was talking to me a few days ago, and he was also in the opinion that you should cut down and get the students out of the training program as early as possible. So his thing is that you can cut it down to easily 4 years or something like that, and then necessary changes in the Sri Lankan Medical Council and other places should take place. So in fact, online assessment is going to take place. So I think certain universities are already doing that. Now, certain things cannot be changed. Having said that, now the practicals cannot be lab-based training, the hands-on experience. Now, that of course need to take place in the usual manner. Same things can be said about the clinical training as well. Now, Zoom patient discussion, I think Professor Bodhinaga has done one, and she told me that was a very effective one. And in fact, the consultant who called me from Colombo also said that he has done one on surgery and then it went on very well. But I don't know whether you can entirely replace the clinical training that is required with that kind of, teaching mode. And perhaps not, because people thought that doctor-patient relationship is where the tactile component is one of the important ones. You place your hand on somebody's shoulder and pat on your back and say, you are going to be all right. And then, oh, I'm going to take care of you. And think that kind of assurance, you can probably not get that through that kind of teaching mode. I think you may have heard about that touch humanizes the doctor-patient relationship. And now we say don't touch, but again, touch, a tactile component is one of the important things in this doctor-patient relationship. Now the healthcare. The healthcare, there will be what are called inevitable consequences, but these are not actually particularly specific to COVID. But the postponement of surgery, the procedures, and then patient becoming more severe and inoperable during the time duration, those are inevitable. But then it doesn't happen only on the COVID, because it can happen even after doctor's strike. The doctor's going to strike for 2 months, and then this kind of thing happens again, and we know that. And also poor control of NCDs. We all are very concerned about this. Patients who are not getting enough medication and not getting their testing, and also no one is checking on their controls and all. And then there will be more complications and more deaths related to NCDs. And also that what are called the long-term effects of COVID-19 due to tissue damage is a huge debate. If you go to the internet and then see this, and then people are contemplating, or people are thinking that the effect of the long-term effects of this infection and would persist for years and years in certain tissues. And certainly one that people is really thinking about is what is called the chronic lung disease. And it is not completely a pneumonia. It is a tissue destruction due to thrombosis within the vasculature, as I understand. And then that kind of tissue damage and certainly would cause certain problems in the years to come. So chronic cardiac disease, like something called cardiomyopathy post-COVID, whether you will be writing a diagnosis card 10 years after saying that this patient got a cardiomyopathy post-COVID or something like that, and I don't know, and a real possibility. And the renal disease seems to be a transient and a temporary one, but then even then people had to follow up those patients and see whether the COVID has left a long-lasting tissue damage in those systems, and so that patient will have continuous disability. The psychological impact, and people talk about the psychological impact of the disease, and then it's something we should not be ignored. We spent sleepless nights, and I should admit that when Sri Lanka was recording one patient, 2 patients, 3 patients, and we were happy, and then suddenly jumped to something like a 22 patient all of a sudden, and then probably some of her had a sleepless nights and thinking, hang on, have you started the peak, and where it's going to go and end up like? Because the one of the study which has been submitted for publication now and almost accepted, and says has predicted what would have been the patient case load in Sri Lanka if we did not have all these sort of measures to flatten the curve, and taking the incline, that the steep, that what is called the gradient, and these people predicted that there would have been 500,000 cases in Sri Lanka. So the number that we were heading for is something like 500,000 patients in Sri Lanka, and then we had now cut it down to maybe about less than 1,000 cases. So you can imagine that as earlier the people said that if you had a 500,000 cases, and then 20% will have severe symptoms, and the 5% of them will require hospital admission, and half of those people will die. And then you could imagine how many deaths we would have had, and then what we have done fantastically to avoid something like that. So, and then the mental health impact is need to be considered, and the mental health impact arises due to 2 things. One is that the disease, the fear of the disease, and then the economic concerns, people unable to do jobs. And then there's a nice chart in the internet that we promote what is called the working from home, but then when you look at it's the poorest people are the people who can't do that. Let's say a carpenter, a mechanic, and then he can't do that really. But again, people who are in the upper strata of the economy, and then social strata, and they can do that. So what will happen that if you have that kind of situation for a long time, and certainly it's going to widen the gap between the poor and the rich and all, because those people will never get any work, and those people can do part of their work. The lung scarring, as I said earlier, is something people are very serious about, because 1/3 of SARS patients had a scarring in their lungs, and then they continue to have symptoms. And post-COVID lung scarring people have reported, and whether this will lead to something like a lung fibrosis, diffuse lung fibrosis, and then bronchiectasis, something like a traction bronchiectasis later on, and whether you will deal with some kind of restrictive lung disease due to post-COVID, and no one knows. So you have to wait and see. So I won't be surprised if we have to deal with patients who have got restrictive lung disease due to COVID. So these patients, come as a cohort. Now the selection of jobs. Now people already started doing what is called the risk categorization. So estimate the risk and then categorize what's called the high risk, and the very high risk, intermediate risk, and the low risk. And then on the other hand, when they do that, actually they look at how much remuneration or how much earning these jobs give you. Let's say you can do a high risk job and gives you a lot of money, and somebody might think about it. But if the high risk job is not going to bring a lot of money to you, and then probably you will avoid doing that. So what people are trying to do is to bring to a balance between what is called the risk, amount of risk that somebody would face in a pandemic like this, not only in this one, any pandemic to come, and then how much money that they would get, the salary that they would get. And this is what is called the risk estimation. So you can see in the first category, you can see what is called the contact with others, that is maximum, and the physical proximity is not there. They are very proximate to the people, and also exposure to the disease is very high. So like a dental hygiene, people in the hygiene, among the frontline doctors, there are special category of people who are very really exposed to diseases. So these are what I call high risk. And then come to the next one. It's not that really what I call bus drivers. Let's say ambulance driver. Ambulance driver would have a certain amount of risk, but not that much really. So it will be in the intermediate category. And then there are other economists who can sit at home and then have no exposure to patients and haven't seen anybody, and then they have no contact with the others, and that fellow has no risk at all. So if that brings a lot of money, and then people will certainly think about that kind of job in the future. Now, the selection of specialties, how does it apply to you? The selection of specialties. Now, dental surgeons, the emergency medicine, people who are in emergency medicine and ICU, anesthesiology, internal medicine. Now, this is the kind of list that I could think of. I'm sure there are other people as well. And then think of people who we have a fairly what shall we say, high risk of getting infection because they are frontline, they are exposed, and so that people will have to think about would I do emergency medicine as a career, and would I do anesthesiology, or I'm going to be intensivist or something like that. Now, I think Dr. Hera could remember, I think we have been discussing that, high infection rate among the frontline staff. And there's at least 1 or 2 studies saying that, it's a frontline people had enough precaution. They took enough precautions in handling these cases, but then went to non-frontline people and they didn't have that much of precautions, and then they got infected more and they have a higher risk of getting infections. So this kind of risk categorization, again, we have to think about. This is what I said earlier, risk category, there's a risk score, and then on the last column, and say how much, sorry, on the second column, how much money that will bring. So people have to think about it. People will think certainly, when you select something like that. This is not a list for that you can look at and say where you are really, because this is done for another country. But certainly, when you apply for a job, you will think about these things in the future, and when you're particularly selecting a specialty. And certainly, you can do a high risk job, but again, it should bring a lot of money in that case. Now, there will be opportunities. Always, we said there's a silver lining, and that also the odd things, the bad things has got good things within that, and then you have to look at these opportunities. So one thing is that medical informatics is going to come into front, out of all this in a big way, because now people think that it's going to be a game changer. It's going to change the way the medicine is sort of, delivered to the people's doorstep. Now, as we have been doing telemedicine before that, the curfew was lifted and all patients were able to come to the hospital. And then I know quite a lot of doctors who are doing telemedicine where the patients sort of, show you the reports and this and that, and then, give advice. So telemedicine came to Sri Lanka as well. And the digital health and the artificial AI is going to be a huge factor in the future. And this is something that people can think of, that, if you are not decided yet, that you will do internal medicine, genomes or pediatrics, and then you can think of some of these things, in the future, because there'll be going to be a lot of money for this, and there'll be a lot of emphasis on this in the future. Now, did Sri Lanka did wonders in this one? I believe yes, because who thought that Sri Lanka will make robots? And the other person, Virat, said that, there's engineering faculty students have made robo, and then, they didn't know where to give. And so I was trying to send it to Hambantara Hospital. And so people actually put their hands up in this developing technology, and also they were not far behind, other countries when it came to that. So they did quite wonderfully, and developing these robots and then, this type of thing, and where you could minimize the patient contact with the frontline staff. Now, have we learned lesson from the Spanish flu? I think we have. Now, rapid notification. If you know that, I think it was Champa's lecture. She said that, we had the first case in the world was reported on 31st of December 2019, if I remember correct. And then the 7th or something like that, they submitted they knew it is a new disease. And then 2 weeks later, they had a genome and they had a genetic profile of the virus. So within 2 weeks, within 1 month, they knew everything. So the rapid notification led to the rapid suspicion of cases when they came as a cluster that we have got a new disease, and then in our healthcare, and then identification of the positive organism, and which happened very early. And then that was a plus point. I think this is people who are who looking at what are called the developments in the healthcare systems and all. These are the real development in the healthcare system, which we did not have about 100 years ago. And then once the genome was identified, and then of course they were able to get the what I call a screening and the diagnostic test, and then they came very, very quickly. The people knew about the mode of spread, which had no idea about the Spanish flu. And then we know which mask to be worn, and then, things like that. Though there was a little controversy about the mask, and the mask, and whether to wear a mask or not wear a mask and all. But then, people again thought that, which kind of mask would prevent the spread of the infection. At least they knew that, whole country, they don't have to wear N95 or something like that. And also we had idea about what's called infectivity, and that is called R value. I think I probably heard about that, what's called R value. And then also the severity, and because studies came, and then we learn about this very quickly. But then two things which I have not done, drugs and the vaccines. So still, we didn't have them in Spanish flu 100 years ago. We still don't have that. I mean, if you listen to that, when I listen to this Dr. Hero's lecture, and absolutely, I thought he's going to show only one slide and saying that we have no drug, we have no vaccine or something like that. And absolutely, we are in a situation, we have no effective drug, we have no effective vaccination against this. So how the whole world will be focusing on this now. Now, there will be more opportunities in virology, because people will develop what are called the rapid methods in isolation, and the more accurate screening and diagnostic methods, as I know that, that the reverse transcripted PCR that we have got in place has got about 70% sensitivity at its best, I believe. And then that means that, 30% can go wrong. And so you need to have repeated testing if you want to catch about 90% at least. So there'll be more accurate screening and diagnostic methods. So the virologists will have more work. So it's something that you can think about. And also pharmacology, because it's pharmacology, depends on pharmacology, what I call antiviral medication, and also vaccinations, so clinical trials, and this and that. There'll be a lot of avenues in those areas in the years to come. So summary, the world is not going to be the same again. So that's for certainty. And certainly it's not for the healthcare. Healthcare are going to be different. And how we deliver healthcare, and all that's going to be different. And I'm sure there'll be more funding on digital health. I haven't seen anything like that at the moment, but again, I'm sure that, people will fund, like, what I call these organizations, and the charity organization, and they will have, I think even NSF, I think this thing came recently saying that NSF, that's a funding available for this type of thing. So there'll be funding for digital health in the future. And there'll be more research on antiviral drugs and vaccines, and I'm sure people will develop what are called the antiviral drugs, which are effective for different types of virus, like, different broad spectrum antiviral drugs in the future, rather than focusing on one particular virus, because that will come for the rescue and in the future epidemic. In medical education, there'll be things, attempts, people will try to shorten the duration of this thing. So that's all. You stay safe wherever you are, and until we see you. Okay? Thank you.
Thank you, sir. Thank you very much for that very informative lecture.
Thank you.
I think it's question and answer time. If you have any questions, you can ask now. You can send that message.
I have a question. Can I ask this from Lekam Masan side, sir?
Okay.
Sir, with regards to the vaccine, because you touched on the vaccine, is there like a particular way that they will prioritize on certain countries, and like the more exposed people, like the healthcare staff, that because there's still like the vaccine, all that research is going on when it is produced, will there be a system that they will do the delivering of the vaccine?
Very, very interesting thing, really. In fact, last night when I was reading something, I realized that there are 80 clinical trial vaccines are being sort of tested at the moment. But then the protocols are not very well known. And then Canada recently took a lot of precaution, because they thought that their database will be hacked by people outside. So yesterday there was a statement from, I think it was from Canada, and then saying that, they are taking extra precautions so that people will not hack their database on this particular particular regard, the vaccine. So people are still that, all this, but then at least 80 vaccines are being tested currently. And but then, the details of these we are not available to us yet. But then, so people are certainly giving the priority for this vaccine, development of vaccines.
Okay.
Any more questions?
Can I ask a question? Yeah,
yes.
Can I ask a question? Yeah, okay. Right. Now I saw that, there's lots of people advertising, advocating what is called vitamin D. And then they found a huge link between vitamin D and then the severity of the infection and the incident of the disease and the mortality and all. But how much do you know about it? And then I wonder whether it is again kind of people drawing attention to the wrong topic. Because this morning when I punched the word COVID-19 and the vitamin D in the PubMed, I got 27, and all 27 were review articles. And then when I say filtered by clinical trials, there wasn't a single clinical trial on vitamin D. And so have you heard anyone heard about this vitamin D thing?
Not really, sir. I don't think that there is any clinical trials as such done on to find out whether there is any benefit of vitamin D on COVID-19. Of course, I think that is not the primary focus for the moment, I guess. Because I don't think that vitamin D is effective apart from bone diseases. I don't think that it has been shown to be effective in any viral diseases. So I don't think that will not be the primary focus. But as far as I'm aware, there is no strong association between vitamin deficiency or vitamin intake with incidence or any bad outcome with COVID-19.
Yeah, that's right. I was thinking on the same line. But then there are some sort of prominent, let's say, intellectuals are arguing, saying that you get more death in the USA because those people are vitamin D deficient and they're in this winter, and where we know during the winter their vitamin D can be pretty low, and so they say that they are not worried about the USA people in the Europe people dying because they say that's due to vitamin D deficiency. And I don't know, because unless they want to sort of console themselves saying that our healthcare system fantastic, but then people are dying because of vitamin D deficiency, I'm sure you can think. But then I haven't seen anybody doing that kind of epidemiological study.
That's correct. I don't know whether it's just association with this causative effect, no sir. I mean, of course, first and foremost, we don't know whether there's strong association, and second, we don't know whether it is causative effect also. Even if
vitamin D and Sri Lanka also, there's a little bit of talk about that. I don't know whether you are aware of that. There's a little concern. I will send you the link.
Okay, sir. Right. And in fact, one of the students has suggested to do a proper lecture on PCR, full PCR testing. Of course, that is quite relevant. Also, I guess. So we would ask Dr. Gaya to do that, because I think there's a plan of doing PCR in the faculty. So we will ask him to do that full procedure. Of course, they won't know. And what is one of the student has asked from Professor Lekam Masam about the second contact exposure. So what is meant by second contact exposure? So are you there, sir?
I'm here. I didn't say anything about it actually. So is there a second contact? You get a first contact and the second contact. So let's say if a patient positive has, let's say, wife would be a first contact, hopefully. So if let's say if a Navy soldier and who is positive, when he went home, his family members would be first contact. That's what I believe. Okay.
That's correct.
Let's say if the family members visited temple, let's say they went to temple, I think the priest in the temple would be second contact. Is that, am I correct? That's what I understood.
That's correct, yeah.
Yeah, so first contact would be people who came to immediate contact with the fellow who is positive, tested positive. So that will be a wife and the family members, blah, blah, blah. And then if the family members sort of, visited temple or went to shopping or this and that, and the people in those locations would be second contacts. That's what I understood from the first contact, second contact listing.
Yeah. Okay. And also there was a question on drug treatment. One of the students has asked whether the HCQs
if there are no questions, can you let me go? I got some.
Yes, I think probably you can leave.
Okay, right.
Yeah.
Thank you very much. Okay, so you can continue.
Yeah.
Okay. Thank you.
The question is on drug treatment, whether there is any benefit, whether any of these drugs has any direct action against the COVID-19, COVID virus rather. The answer is, in fact, there are in vitro studies showing some benefit, but of course, when it comes to the clinical practice, when it comes to real life situation, there is no such benefit at the moment. At least there are no evidence. At least there are no evidence to say that these medications are effective against COVID-19. The results are quite conflicting. Some studies are showing some benefit, but most of the studies are showing no benefit. So we really don't know. Right. Any other questions? Since we have, I think, probably gone beyond the scheduled time, probably we can stop that if there are no further questions.
Excuse me, sir.
Yeah.
So after patient got infected by COVID-19, does he can pass the infection to the others after he recover?
Well, I don't know if this guy is around, probably the guy should be able to answer, but having said, I mean, if the patient recovered means patient has fully recovered. If the patient has fully recovered, there is no way that the patient can spread the disease to others. But the question is whether, because some people take some time, so what they do is generally they do two PCR testing, and both testing has to be negative. So generally they perform, depend on the viral load. If there's high viral load, they perform PCR testing on day 14. And if the patient has low viral load, generally they perform PCR testing maybe on day 5, day 7. And if that test is negative, probably in few days time, maybe 2 days time, they do the second testing. Both tests are negative and the patient is completely normal, they would discharge. So one of the discharge criteria is the PCR test has to be twice negative. So if they have cleared the virus, if the patient has completely cured, there is no way that the patient can spread the disease to others. But question is, if the cure is not properly diagnosed, if the patient is discharged from the hospital without recovering, there's a possibility that the patient can spread the disease to others. So otherwise, the chance is very much less.
Dr. Herath, yes, I do agree with you. I'm Gaya here.
Yes, yeah. Please go ahead.
Yes, the patient can clinically recover, but he may continue to spread the virus. So that's why we need repeated testing. If you can go back to our very first case, the Chinese woman, we know that she was recovered, but we didn't discharge that lady for another couple of weeks because she was still spreading the virus in the respiratory secretion. So we have to do repeated testing. And once 2 back-to-back tests are negative, then we can release the patient.
Gaya, is there a chance that this excretion goes beyond several weeks, and at the latter stages, the virus is little defective? So actually, though the virus is excreted, it is defective to cause infectivity.
Well, madam, we have to study it more. I think there are cases which even spread virus more than 6 weeks after the recovery.
Yes, so, but they are pretty much defective and their infectivity is low. That is what
Yes, agree. But then we have to do proper studies whether they are, how much they are infective and the infective dose and everything.
Exactly.
Yeah. In fact, some of these reinfections are thought to be due to just a viral particle which are there in the sample rather than reinfection, of course. I think there were a couple of cases of reinfection in Sri Lanka, and also I think there were a couple of cases of reinfection in the countries also. I think all those reinfections were thought to be due to just a viral particle which are there in the previous infection rather than real reinfection. Gaya, there's a request from students to do a lecture on proper PCR procedure.
Yeah.
Can you please arrange that?
Okay.
Right. What is? That's all. I think there are no other questions here in the chat box.
Excuse me, sir. I do have a question.
Yeah.
Sir, how long it takes to start viral shedding after contacting with the COVID patient? Approximately about.
You mean that is before the symptoms develop?
Yes, sir.
Gaya?
Yes, 2 days before the symptoms, they start shedding. 2 days before they are symptomatic.
So does that mean there's a risk of spreading disease even via the second contact patients also?
Well, anyone who is exposed, he may be incubating the virus, and during the latter part of the incubation period, he starts spreading before they become symptomatic. So it's same for even for the contacts.
In fact, that is what happened for Navy soldiers also. I think most of them were asymptomatic at the time of the diagnosis.
Yeah.
So they were diagnosed based on the PCR. That means they were shedding the virus. So some of them were true asymptomatic people. That means they never became symptomatic. Some people, of course, had developed symptoms subsequently. That means they were symptomatic, but they were detected during incubation period. So a few days before developing symptoms, they start shedding virus. But some people remain asymptomatic throughout the illness.
Also known as pre-symptomatic spread.
That's correct.
Yeah.
There was a question on health economic basis. I think Professor Lekam was not there. So yeah, that's all I think. I think since there are no other questions, shall we stop the meeting here? Thank you very much for all of you for your valuable time and preparation made for this presentation, for this seminar. Thank you very much for all the speakers. Thank you very much, students, for joining this important seminar. I hope that knowledge that you gain from this seminar will be useful for your activities, particularly once the faculty started, to protect yourself as well as protect your patients. Thank you very much for joining this meeting. We'll stop it here. Thanks.